County in Dayton, Ohio, lies at the heart of America's opioid crisis. Dayton is nestled in the southwest corner of the state and has earned an unfortunate reputation as the overdose capital of America after racking up 365 deaths related to opioid overdose in the first 5 months of 2017. However, Dayton is only one city in an entire state struggling with opioid addiction. Ohio leads the nation in opioid-related overdose deaths, even though prescription opioids are becoming less and less available. Only 15% of opioid-related overdoses are the result of prescription opioids, while 58% of opioid-related overdose deaths in Ohio could be attributed to fentanyl, a powerful opioid readily available on the streets.
Stories like Justin's are common in Dayton. Chronic pain often leads to an opioid prescription for pain management. These patients then become dependent on the opioids, and when their physicians stop prescribing, they turn to street alternatives like fentanyl.
One might expect that the overdose capital of America would have a multitude of treatment options available for opioid-dependent patients, but the state of Ohio only has the resource capacities to treat 40% of the opioid-abusing population at most. Only 13 healthcare facilities in the Montgomery County area offer medication-assisted treatment, or MAT, which has been shown to be the most effective treatment modality for opioid addiction. MAT addresses the biological, psychological, and social aspects of this complicated condition, helping opioid dependents work toward recovery and avoid potentially fatal relapse into opioid abuse. The sheer number of addicted patients outweighs the state's current capabilities for treatment, justifying the label of epidemic used to describe the opioid crisis.
The opioid epidemic is a complex problem with many different causes attributed to it. To single out only a couple causes as the main culprits would be reductive. However, a couple main factors have the largest impact on the epidemic. It's believed that if we address these specific problems, that we can significantly reduce the opioid epidemic. First, the causes must be divided into two categories: patients and providers. The patients category represents the individual situation and/or responsibility of each user. For example, it is believed that many users have poor coping mechanisms, which increases the chances of them abusing drugs when under stress. Instead of seeking out help or other resources, additionally, it is also believed that users lack proper education on the resources that are available to them. Many opioid users use public health insurance. However, very few of them know that they can obtain transportation to and from treatment using their insurance.
In Justin's case, patient-specific factors contributing to his opioid dependence included chronic back pain, unemployment, and financial difficulties. All of these factors contribute to intense amounts of stress for patients like Justin. Without healthy coping skills, it makes sense that some patients may turn to drugs.
The providers category represents the responsibility of treatment providers. Primary care providers prescribe opioids too readily to patients and far too often. This increases the likelihood of developing an opioid addiction to pain pills. This is spurred by the decision to make pain a purely subjective experience, a primary health indicator, thus forcing physicians to prescribe pain pills even when the situation does not necessarily warrant it. With regards to addiction treatment, medication-assisted treatment centers are far too few and far in between, which means that most drug users have no access to treatment centers, even when they want to become clean. Even worse, treatment centers often have unreasonable and unrealistic standards for their patients. Patients are required hours of group therapy during the week, followed by doctor's appointments, which are often scheduled during the afternoon, in the middle of a typical workday. This means patients are forced to choose between having a full-time job to survive and going to treatment. Even then, treatment centers are often overly stringent with their obligations, and even minor infractions are grounds for expulsion.
Community efforts to combat the opioid crisis in Dayton have been monumental. Public health, medicine, law enforcement, psychology, social work, many local agencies in a number of fields have banded together to tackle this issue. Thankfully, the community's work appears to be paying off, with the rate of opioid-related overdose deaths slowing toward the end of 2017. We look forward to continuing this positive trend with the development of a front-end strategy, preventing addiction at its roots, and intercepting substance abusing patients like Justin early on to stop abuse.
This is a multifaceted topic with a number of stakeholders and complicated factors, so we want to target the areas of this issue that we feel will have the greatest positive impact. Our strategy will focus on healthcare providers as part of a targeted public health response to this issue. Within the realm of prevention, we will address the patient-physician relationship and provider education on the subject of substance abuse. To address early intervention, our strategy discusses precautions to be taken after the prescription of opioid medications and the accessibility of treatment centers.
Prevention of the initiation of substance use is key to reducing the overall impact of opioid abuse. For those who have already started on the path to opioid dependence, early intervention minimizes morbidity and mortality in this population. If dependence is caught early, the progression of use from prescription opioids to heroin to even stronger formulations may be halted. From the perspective of prevention, we hope to address the provider-patient relationships and provider education. Establishment of a trusting relationship between the patient and provider is key to the prevention of addiction. If Justin is comfortable with his provider, he's more likely to bring up the sensitive topic of substance abuse, should it ever become a concern. However, it is the responsibility of the provider to regularly screen for behavioral risk factors surrounding substance use. The patient's substance use or attitudes towards substances should be a routine discussion, so that if problematic behavior should arise, it may be addressed early in a safe environment. With a long-term, trusting relationship, detection of inadequate coping skills and persistent behavioral patterns is facilitated. Regular healthcare visits also allow for patient education surrounding substance abuse consequences and risk factors. To ease the development of this relationship, we should encourage changes in compensation structure at the policy level so that providers can spend more time with patients.
Another important aspect of prevention is provider education. Regular discussion of substance abuse prevention and management is integral to increasing provider comfort with the issue and reducing the prevalence of provider-held stigma towards addiction. Unfortunately, though most providers believe that the primary care setting is appropriate for substance abuse treatment, many view patients with substance abuse disorders negatively. This population can be emotionally challenging to manage and is often perceived as high maintenance, manipulative, or poorly motivated by providers. As Justin's mother is aware, substance abuse can predispose a patient to erratic behavior that families and providers alike often find difficult to manage. It doesn't help matters that primary care offices are not compensated for additional effort associated with substance abuse counseling and intervention. We propose that physician education and exposure to addiction should begin in medical school. Psychiatry rotations in the clinical portion of medical school do not always include exposure to addiction medicine and substance abuse. However, such organizations as the American College of Physicians and the American Medical Student Association may lobby for the mandatory inclusion of these topics in psychiatry education through the Liaison Committee on Medical Education, or LCME. The LCME oversees curricula in medical education, and though individual medical schools are allowed to integrate substance abuse education, it is not currently mandated on a national level.
After graduating from medical school and becoming licensed, physicians in primary care may seek out opportunities to deepen their understanding of substance abuse issues and expand their therapeutic influence by securing a waiver to prescribe buprenorphine. Buprenorphine is a relatively safe opioid medication that can be used to help patients wean themselves off more dangerous opioid formulations. Before the year 2000, only addiction specialists were able to prescribe medications, but the Drug Addiction Treatment Act of 2000, Data 2000, loosened those restrictions so that buprenorphine treatment may be more accessible to the primary care setting. Data 2000 training helps with substance abuse prevention by educating providers about the presentation and management of this condition.
Overprescribing by physicians was a major contributor to the development of the opioid crisis, but in response to the growing number of opioid-related deaths, many physicians are now cautious of overprescribing opioids. Still, it is important to reinforce the potential impact of prescribing habits on opioid dependence. Efforts such as Think Again initiative in Ohio encourage providers to pause for a moment before prescribing opioids and evaluate the ramifications of their prescription. Does the patient have a history of substance abuse? Are there other non-pharmacologic options that can be considered for pain management? These are important questions for the physician to consider before prescribing a potentially fatal medication for pain.
Some patients will require opioid medications for adequate pain management. In these situations, ongoing caution should be taken by the provider after prescribing opioids to facilitate early detection and intervention of any emerging problematic behavior. Recognizing the potential risks, providers should regularly monitor the patient for behavioral and physical cues that may indicate an issue, as well as educate the patient on what to watch out for. If problematic behavior is noted, the provider should be well informed of indications for referral to a specialized addiction treatment center. Many primary care providers can manage patients on Suboxone, but patients with severe dependence, a need for medical detoxification, or complicating health conditions may need to be referred to more specialized management.
The next level of care after medication-assisted treatment in the primary care setting is a specialized intensive outpatient program, or IOP. IOPs generally require several hours per week of attendance at individual and group therapy, the equivalent of a part-time job. The accessibility of such programs is currently insufficient for effective treatment of addiction for a variety of reasons. Such reasons include stringent attendance requirements that may interfere with the patient's employment responsibilities, inflexible hours for treatment, and a limited number of programs. Treatment centers, as stakeholders in the implementation of this strategy, should consider shifting more mandatory sessions to weekends or evenings to allow patients with full-time employment or other responsibilities to accommodate the treatment into their schedules. Additionally, tardiness or absence due to life circumstances should not be met with immediate dismissal from the program, as is the policy in some programs.
Flexibility and understanding are key to integrating recovery efforts into a patient's life. Treatment centers need to cooperate in this effort to ensure that access to treatment is maintained and recovery is supported in the context of the patient's life. Finally, we need to increase the number of spaces available in these intensive treatment centers to better accommodate the substantial number of people struggling with addiction. Treatment should be accessible to everyone with a problematic behavior towards substances. Our goal is to prevent complications rather than retroactively treat deep-set behaviors after years of substance abuse.
Healthcare providers and public health employees are integral stakeholders in this strategy, and their involvement in prevention and early intervention of substance abuse will have a substantial impact on addiction in this region. For Justin, it is unfortunately too late to prevent his problematic relationship with prescription opioids. However, our strategy addresses multiple points to intervene at this point to minimize the damage caused by his substance abuse and help him towards recovery. In future encounters with healthcare, the Think Twice initiative will prompt Justin's providers to consider the ramifications of an opioid prescription. His providers will take the time to ask about Justin's feelings and his behaviors surrounding substance abuse, and building and maintaining a positive relationship that supports recovery. Expanding access to treatment, either through medication-assisted treatment at the primary care office or an intensive outpatient program, will help Justin get the care he needs to overcome addiction. Fighting addiction with willpower alone is a steep challenge, so every bit of support medicine and public health can offer is valuable.
This plan will substantially improve the health of the Dayton area by reducing the number of new and existing opioid users. By improving education and providing accessible support systems, patients will be less likely to resort to drugs to cope with mental illness or difficulty. Furthermore, physicians will prescribe fewer opioids to patients, and treatment centers will improve their policies in dealing with patients and improve their rates of success. The progress and improvements from this plan are measured in three main metrics. 1, reducing the number of new opioid users each year. This will help measure prevention and early treatment. 2, reducing the number of existing opioid users each year. This will measure early treatment and improvements in patient-provider relationships. And 3, reducing the number of overdose deaths each year.
The challenges and barriers addressed in this plan are numerous. First of all, proper education on the resources that patients have will allow them to properly utilize them to access support and treatment services. By removing pain as a health indicator and encouraging non-opioid pain management, primary care providers will not have as much pressure to prescribe opioids to patients. Increasing the number of treatment centers, especially in high-need areas, will allow addicts to access timely treatment services when they make the choice to seek treatment. Treatment centers will also loosen the restrictions and create more reasonable and realistic treatment programs that should allow a patient to maintain a job while also going to treatment. This should keep people in treatment for longer periods of time and increase the rate of successful treatment.
For most of the measures suggested in this presentation, the associated costs would be solely administrative. For example, for the use of screening guidelines, the only direct cost associated with the implementation of this would be the man-hours to program the screening guide into the electronic health record. In addition to this, exposing medical students to addiction treatment during rotations has minimal continued financial commitment after initial administrative costs to start up. The programs that are directed to practicing physicians, such as the education about prescribing habits and the Data 2000 program, could be covered under existing continuing education credits.
The opioid crisis has received a well-deserved windfall of attention, but opioid dependence is only one aspect of a deep-set mental health issue in our country. Unfortunately, as the prevalence of opioid use decreases, addiction to any substance will likely always be a concern. Our strategy addresses addiction at its core and will not become outdated as the next trend in drug use emerges. Prevention of unhealthy behaviors and early treatment seeking are relevant and helpful for any substance abuse.
We live in a society of opioid use. People want to feel better and they want to feel better fast. And because of that, opioid use has become more and more prevalent. Whenever somebody breaks a leg or pulls a tooth or gets in a car accident, they want those pills and they want them now. What we need is to change that culture of opioid dependence. We have to change that culture of treatment seeking and pain management. One of the biggest problems that many providers face is the use of pain as a fifth indicator of health. We need to change that. And moving forward, our culture and the culture of providing healthcare should not depend on pain. And we should teach our patients that pain is a normal thing and it's expected in treatment.
Addressing such a complicated problem requires a great deal of brainstorming, and several proposed plans were discarded by our team for a lack of feasibility. One suggestion was a multifaceted approach addressing multiple points along the arc of addiction, including illicit drug supply, prevention, early treatment, harm reduction, and relapse prevention. Though ideally multiple agencies would collaborate to ensure that each of these critical points is addressed, our team felt that a more focused strategy honing in on the root cause of addiction was more viable and productive.
Addiction is a complicated condition with a devastating impact on our communities, especially here in Dayton. As substance abuse progresses, more psychological, physical, interpersonal, and spiritual problems are created. This makes deep-set addiction even more difficult to overcome. The most important factor in our strategy is the understanding and knowledgeable provision of care and counseling by healthcare providers. We believe that targeting the prevention and early intervention of substance abuse is the most effective means of reducing the harmful impact of addiction and promoting recovery in our communities. These are our neighbors, friends, and family members, and they deserve the attention of public health efforts.